بسم الله الرحمن الرحيم والصلاة والسلام على نبينا محمد الصادق الوعد الأمين. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. السلام عليكم ورحمة الله وبركاته. I'm Dr. Adel Al-Babtain, Consultant Obstetric Gynecology in MOH, Deputy Head of NTP National Training Program. Welcome to the third COVID-19 webinar in pediatrics organized by the NTP. We are very impressed by the response from the previous surgical and obstetrical gynecology webinars. The viewers reached more than 2,500 through the great number of the viewers in different links. The title of the webinar today is the Pediatric 2020 COVID-19 era. COVID-19 have affected the adult and also the children. But luckily enough, the pediatric patient who was diagnosed as COVID-19 positive are either asymptomatic or mildly symptomatic. But unfortunately, those who are below 1 year old, they are more likely to suffer from the critical illness and they might need admission to the pediatric ICU. 90% of the children in China had mild to moderate symptoms. However, there are many challenges in the management of COVID-19 in pediatrics. As the child does not speak for himself, and children usually they need you to speak for them. So they may not even announce their symptoms or complain. So you have to have high vigilance in order to diagnose their illness. There are also challenges during the resuscitation of the child. And this topic is going to be tackled by, in this webinar in details and discussed in details by Dr. Fatuma. This webinar is going to be divided into 3 talks. The first one is Dr. Fatuma Al-Abdrazak. She's consultant pediatrician, and she will talk about pediatric resuscitation in COVID-19 era. The second speaker is going to be Dr. Layla Al-Kindari. She is consultant pediatrician, and she will speak about management in the emergency room for pediatric with COVID-19 positive patients. The third speaker is going to be Dr. Munira Eliasin. She is third year Kuwaiti board. She will speak about management of COVID-19 pediatric patients in the ward. So we will enjoy, inshallah, this webinar. I will leave the mic now to Dr. Fatuma. Thank you.
Pediatric resuscitation in COVID-19 era. So I have an objective for this talk is, first of all, to provide you doctors with the new updates in resuscitation in suspected and confirmed COVID-19 cases in pediatric population. So in terms of my outline for this lecture, I'm going to start with an introduction. Then after that, I'm going to talk about some statistics in pediatrics in the COVID era for the past 3 months. Then I'm going to talk about the general principles for the resuscitation in suspected or confirmed COVID patients, in pediatrics. After that, I'm going to show you some updated pause algorithms for the COVID-19 era. I'm going to end up my talk with take-home messages. So in terms of the pediatric populations and how are the pediatric populations was affected by the COVID team, we're going to talk about that as well. So over the last 20 years, there has been a steady improvement and a very huge improvement in pediatric cardiac arrest survival, whether that's occurring inside the hospital or outside the hospital. So that success has relied on the initiation of a proven resuscitation interventions like starting the CPR and doing the defibrillation for those pediatric patients within a fast, short and rapid timing, within seconds to minutes. So why are those changes that had happened over the past few weeks and over the past months, starting with the COVID, I would say, era? Because the evolving and the expanding outbreaks of SARS-CoV infections has created very important challenges to such resuscitation efforts. And that's why we need some modification and some changes for those processes, because we wanted to make sure that the team is safe, the providers who are providing the resuscitation for those pediatric patients are very safe without compromising the safety issues for the patient as well. And I think that we know that COVID-19 is very highly infectious, and we wanted actually to limit the infectiosity to the rescuers or to the providers of the resuscitations. Let's talk about some pediatric statistics in terms of what's happening over the past few weeks and over the past few months in on this era. So children up to date have been not as severely affected by COVID-19 patients. So all of us know that more than 90% of the pediatric population has presented with just mild cases or asymptomatic cases. As of April 6, 2020, only 1.7 of almost 150,000 COVID-19 positive patients in the United States were children who are under 18 years of age. And that was consistent with the rates we're seen in Italy. And that means that rarely, I would say, or very minor percentage of pediatric patients are affected by COVID-19. So children, as we have discussed earlier, seems to have less severe illness, and the rates of the hospitalizations are very low as well. And the rate of the critical illnesses that occurs in pediatric population were as less than 0.6%. Children less than 1 year of age are at higher risk of hospitalization and critical illnesses. This is one of the important things that we have to mention. So for infants, they tend to have a highest risk for hospitalization and for critical illnesses. And mortality due to COVID-19 patients has been only reported in handful cases from the various countries that has been affected by COVID-19. So while these numbers are reassuring and while these numbers are very low, the prevalence of the infection is likely underestimated as the child's ability to transmit the disease. In addition, many children, as we have said earlier, are either asymptomatic or do have mild symptoms, okay, and presumably impacting how healthcare providers consider the risk associated with resuscitating children with unknown COVID-19 status. So there are certain challenges that healthcare workers do have during the practice or during their, I would say, work in COVID-19 wards or in the pediatric emergency department. So let's talk about those challenges. So the thing that all of us know that healthcare providers are at highest risk for having the disease and getting the infections from this disease itself. And the risk is compounded by the worldwide shortages of the personal protective equipment, the PPE, and all of us know about that. So the thing that resuscitations carry added risk to the healthcare workers, and that happens for so many reasons. Let's talk about the first reason. So the first reason is that because the resuscitation carries the risk of a CPR or involves the CPR. So what does what does it mean? Why do we have like the CPR, and why does informing or performing sort of the CPR will have an additional risk of having the infectiosity highly among the healthcare workers? So first of all, because the CPR involves a very highly number of numerous aerosol generating procedure, and that includes like CPR, for example, giving ventilations to the patient using the positive pressure ventilation as well, and intubation for this patient. And during those procedures, as you might know, very high viral particles can remain suspected in the air for as much as 1 hour, and that can be inhaled by the rescuers who are providing the resuscitation for suspected COVID-19 patients or confirmed COVID-19 patients. The second reason is that resuscitation usually, and if you have, for example, unstable patient or a critical patient or a cardiac arrest patient, and that involves or requires numerous healthcare workers to work in close proximity to one another and for the patient. And you know, because the third reason is that there are high stress emergent events in which the immediate needs for patients requiring resuscitation may result in lapses in infection control practices. And these are the main, I would say, reasons that why resuscitation carry an added risk to the healthcare workers for having or for getting COVID-19. So in terms of the general principles for the resuscitation in suspected and confirmed COVID-19 patients, so before entering the scene, all the rescuers should don the PPE to guard against the contact with both either airborne or droplet particles. We have to limit the personnel in the room. They didn't mention exactly how many persons has to be in the room, but it has to be limited in the resuscitation room as well. And I think that whether it's applicable into your institution, you can consider replacing manual chest compressions with mechanical chest compression devices to reduce the number of the rescuers required for the adolescents who meet the manufacturer's height and weight criteria. The other important thing in the resuscitation in the COVID era is to prioritize oxygenation and the ventilation strategies with lower aerosolization risk. And how do we do that? By either attaching, for example, a HEPA filter if it's available in your institution securely, and you can attach it either to the manual or to the mechanical ventilation device in the bath of the exhaled gas before administering any kind of breaths. So the thing that after the rescuers or the providers assess the rhythm and defibrillate any ventricular arrhythmias for those patients in cardiac arrest should be intubated with cuffed tube at the earliest feasibility opportunity, and to connect the ETT tube to the ventilator again with the HEPA filter whenever it's available, as we have discussed earlier. The important thing in minimizing the likelihood of the failed intubation attempts by two things. So first of all, by assigning the best provider for the intubation, so the best chance for the first pass success to intubate. And the other important factor in minimizing the likelihood of the failed intubation attempt is by pausing the chest compression to intubate. If you have the luxury of having the video laryngoscopy, that's great and excellent, and this will reduce the intubator exposure to the aerolized particles and should be considered if you have that luxury in your institution. Before intubating the patient, use a bag mask device or a T-piece in neonates with a HEPA filter and a tight seal. If intubation is delayed, you have to consider manual ventilation with a supraglottic airway or bag mask device with a HEPA filter, as we have discussed in the previous slide. So once on a closed circuit, minimize the disconnections to reduce aerosolization, and this is very important for the rescuers. Another important thing during the resuscitation that you have to consider the appropriateness of starting and continuing the resuscitation. So you have to address the goals for the care with the COVID-19 patients or with the caregivers or the proxies for those patients in anticipation of the potential need for increased level of care, whether this patient, for example, needs to have an ICU consultation or whether this patient needs to go to an ICU institution or to the ICU, I would say, suite. Healthcare systems should consider policies to guide frontliners in determining the appropriateness of starting and terminating the chest compressions, taking into account the COVID-19 status for those patients, comorbidities, and severities of the illness to estimate the likelihood of the survival. There is insufficient data to support the extracorporeal cardiopulmonary resuscitation, so ECMO, for the COVID-19 patients, but we have seen that used in so many patients, whether adult or in pediatric patients and around the world, and here in Kuwait as well. So before you enter, after entering the room for the resuscitation for the cardiac arrest patient or any unstable patient, you need to close the door when possible to prevent the airborne contamination of the adjacent indoor space. Intubated patients at the time of the cardiac arrest, you should consider leaving the patient on a mechanical ventilator, as we have said earlier, with HEPA filter to maintain a closed circuit and to reduce the aerosolization of this procedure. So after intubation, you should adjust the ventilator setting to allow for the asynchronous ventilation, synchronous for only kind of ventilation, just only for neonates. So there is insufficient data in regards to the optimal ventilator mode during the cardiopulmonary resuscitation. You should consider the following suggestion as has been provided by the new updates or the new guidelines that was out a few weeks ago. So first of all, you need to consider increasing the FiO2 to 1. so to 100% oxygenation. So you can use either pressure control or volume control ventilation to generate the adequate chest rise while limiting the pressure to 4 to 6 ml per kg. This is ideal body weight and it's often targeted. So this is the appropriate, I would say, pressure that you can put the pediatric patient, so up to 6 ml per kg and as minimal as 4 ml per kg. You can adjust the trigger to off to prevent the ventilator from auto-triggering with chest compression and possibly to prevent hyperventilation and air trapping. You adjust as well. You have to adjust the respiratory rate at 10 per minute for children and 30 for neonates, 30 minutes per minute for neonates. And you have to assess the need to adjust the positive and expiratory pressure, so the PEEP, the PEEP level to balance the lung volumes and the venous return as well. You have to adjust the alarms to prevent the alarm fatigue as well. Ensure that endotracheal tube or the tracheostomy, if your patient, for example, is in tracheostomy, and the ventilator circuit security to prevent the unplanned extubation. And this is very important because you don't want to, like after all of the effort that you've done, that the patient had extubated himself. If the return of the spontaneous circulation is achieved, set the ventilator setting as appropriate to the patient's clinical status or to the patient's clinical condition. And that's really very important. So let's talk about the prone patient at the time of the arrest. If you have a patient, for example, for whom you suspect, or you have a patient who is confirmed to have COVID-19 and who is in prone position without an advanced airway, attempt to place the patient in supine position for the continued resuscitation. But what if you have a patient, for example, who is obese? Let's talk about that. While the effectiveness of the CPR in the prone position is not completely known, for the patients who are in the prone position with an advanced airway, avoid turning the larger patient or obese patients to the supine position unless able to do so without the risk of the equipment disconnection and aerosolization. This is very important. You can instead consider putting the defibrillator pad on either sides of the chest. So you can put one, for example, in front of the chest and the other defibrillator or the pad, I would say the arm of the pad on the posterior position. And you can provide CPR with the patient remaining in that position, which is in the prone position, hands in the started position over the T7 vertebral bodies. So enough actually with what I have said. I'm going to show now the algorithms that you are familiar with, and I'm going to note some changes that was implemented by the American Heart Association just a few weeks ago. So all of you are familiar with the pediatric cardiac arrest algorithm for 2 more rescuers that's happening in the hospital. And the change here is either for suspected or confirmed COVID patients. So we have noted earlier that we have to tell the rescuers, and we have to advise the rescuers to don the PPE, limit the personnel in the room, as we have discussed earlier. And the thing that we mentioned, if you see the green, I would say, shape on the right side, or the green square on the right side of the slide itself, that you have to attach the HEPA filter to whether to the mechanical ventilation, for example, or whether to the manual ventilation. And this is very important. You have to apply the bag use with a tight seal, and as I have said, with the filter, and you can practice whatever it's been said previously for the BLS, for the pediatric cardiac arrest algorithm for the 2 or more rescuers. So this is the only change, is to don the PPE, limit the personnel, take into the account that you have to use the bag and mask device. If you have the HEPA filter, that's well and great, with a tight seal, of course. And we have discussed about the mechanical, I would say CPR rather than the manual CPR if you have this luxury at your institution. Again, so the thing that this is the algorithm for the cardiac arrest cases. You are familiar like with most of it. The only change again is to don the PPE. We're going to stress the fact about donning the PPE, limiting the personnel, and you can see that in the yellow rectangles here. You have to prioritize intubation and to resume CPR. The thing that you have to post the chest compression for intubation. This is very important. While in the old, I would say, old days, I wouldn't say that like old days, but the era before having the COVID-19, so we used to intubate the patient while we are doing the chest compression, but here you have to pause, you have to stop doing the chest compression while you're intubating for the patient, because you want to limit the aerosolization of this procedure, and you wanted to limit the droplet contact. So if intubation is delayed, you can consider supraglottic airway or bag mask device with filter and tight seal, as I have mentioned previously, and connect the ventilator with the filter whenever it's possible. And you are familiar with the rest actually of this algorithm, and you can actually find that online as well from the American Heart Association website. So my take-home message is to reduce how do we reduce the provider exposure, and what are the changes that we need to implement and to know and to do in our practice, in our daily practice, whether that's in the pediatric emergency department or even upstairs. So first of all, you have to don the PPE before entering the resuscitation room or before entering the room of the patient. You have to limit the personnel who is attending the resuscitation. You can consider using the mechanical CPR device if you have that in your institution. You have to communicate the COVID-19 status to the new providers that's coming actually to the room. You have to prioritize oxygenation and ventilation strategies with lower aerosolization risk by using the HEPA filter, as I have said previously, if available for all kinds of ventilation. You can do that for mechanical, and you can do that for the manual ventilation as well. So you have to intubate the patient earlier with a cupped tube if possible, and connect that to the mechanical ventilation when you are able to do so. Engage the intubator with the best quality of having the intubation from the first time, because it will decrease the aerosolization itself, and it's very important to decrease the infectiosity of the COVID-19 to the rest of the group. Pause the chest compression, as I have said, to intubate. You have to consider using the video laryngoscopy if you have that luxury, again, in your hospital. Before intubation, you have to use a bag mask device or a T piece in place with a HEPA filter and a tight seal. If intubation is delayed, you can consider supraglottic airway, and you have to minimize the closed circuit disconnections. Thank you so much for your attention, and with that, I'm going to end my talk. Now I'm going to present Dr. Layla Al-Kandari. She is one of the pediatric emergency consultants, and she's going to give us a nice talk about how to manage suspected / confirmed COVID-19 cases in the pediatric emergency department. Thank you so much.
Thank you, Dr. Fatoma, for this presentation and excellent talk, amazing. I will start my talk now. We're going to talk briefly about COVID-19 and the pandemic, the epidemiology, clinical presentation of cases presenting with the COVID-19 disease, and the flow charts of what to do in an ER with pediatric cases, and the management. And we're going to talk about brief cases, and then we're going to talk about take-home messages. So COVID-19 pandemic is basically the disease, and the virus itself is the SARS-CoV-2, which is the novel coronavirus causing the current pandemic, current widespreading pandemic. It's a virus that is new to our human population and arises from a combination of viruses of other mammals. This is what's thought it is. The first case was identified in Kuwait, as we live in, on February 24th in 2020, and the pandemic was declared by the WHO on March 11th, 2020. So if we talk about COVID-19, COVID-19 is the disease caused by the virus, but the virus is called novel coronavirus, or let's say SARS-CoV-2. Okay, the novel coronavirus is an RNA respiratory virus, and it is from the corona species or the corona family. It is transmitted through respiratory droplets, and the incubation period is thought to be between 2 to 14 days, and the median for the transmission is 4 to 5 days. then transmissibility is believed to be high, which is higher than the previous corona species that we've encountered, like SARS and MERS. Patients infected with COVID-19 are thought to have mild disease, according to the American Academy of Pediatrics, in 80% of the cases, severe disease in 14%, and critical in 5%. And Dr. Fatuma have already explained the statistics regarding the pediatrics. So this is in general, adults and pediatrics. According to the WHO, total cases of worldwide up until yesterday was 7,553,182 cases, confirmed cases as in by antigen detection or by PCR testing, and the total deaths were 423,000. According to Kuwait census, the total number of cases until today 35,920, and total confirmed deaths regarding COVID-19 is 296. So regarding the clinical presentation of COVID-19 cases, they can range with a different kind of presentations. It can range from very mild cases to severe and critical cases. Now the thing is that children don't speak for themselves. Children need you to speak for them. So a child might have fever or chills. They might have cough, shortness of breath, or difficulty breathing. Some of them, the younger patients might not be able to announce their symptoms, but you should be vigilant to detect them. So symptoms might range with fatigue, muscle or body ache, headaches, new loss of taste or smell, sore throat, congestion or a runny nose, nausea or vomiting, and diarrhea. But these symptoms, even though there are many, they don't conclude the list. As of the last couple of months, we've been presented with a new syndrome. It is the pediatric multisystem inflammatory syndrome. And this syndrome is thought to happen with kids that have been infected or currently infected with COVID-19. So this syndrome, it's very important to be vigilant for and to wait for and to be cautious not to miss it, okay? This syndrome is thought to involve, as the name indicates, multi-system. So it's thought to involve many systems in the body, including the respiratory, the kidney, the heart, and it will have multiple effects on the child. One of the symptoms that we can see, the persistent fever. Usually these kids will present with persistent fever more than 38.5, which will be there for many days until they present. And then they might have hypotension, they might require oxygen, and the many symptoms that can present with, like abdominal pain, confusion, conjunctivitis, cough, diarrhea, headache, lymphadenopathy, mucous membrane changes like redness, neck swelling, rash, respiratory symptoms, sore throat, swollen hands and feet, or peeling if later on, and syncope and vomiting. Now these symptoms, if a pediatrician looks at these symptoms, if you can pick and choose symptoms that fit into the diagnosis of Kawasaki disease, which is one of the syndromes that's thought to be part of the pediatric multisystem inflammatory syndrome. And it is thought to overlap because patients presenting with pediatric multisystem inflammatory syndrome might have the effects of Kawasaki disease on their organs. So I thought of sharing this quote with you. Taking care of yourself is the most powerful way to begin to take care of others. So I posted this quote to tell you guys out there in the front lines, you have to take care of yourself. You have to be prepared and wear your PPEs just before even thinking of seeing a patient. It's basically the key to continue giving care to others. So once you have a patient that you suspect that from the screening questions that this patient might have COVID-19, first of all, put the patient in the isolation room, take a proper history, of course, don your PPE before going in, and then take a proper history, take a timeline of the symptoms, contact, quarantine history, and going back to the timeline of symptoms, very important to ask about the red flags, as we've mentioned earlier. The red flags about the multi-system inflammatory syndrome in pediatrics, like the symptoms of Kawasaki disease and the toxic shock syndromes. And then going to the examination, take proper vital signs with the triage, the heart rate, temperature, respiratory rate, saturation, cap refill, and the blood pressure, and then proceed with a physical examination. Of course, you will do a proper physical examination from head to toe, according to the case. And then for suspected cases of COVID-19, you have to proceed with the investigations, including the CBC, CRP, CK, PCT, ferritin, troponin I, LDH, RFTs, LFTs, and PT-APTT INR, which is the coagulation profile, blood culture, G6PD level, and MRSA screening. I'm going to go through the flow charts. These are provided by the Ministry of Health, and this is the last update, which was published on the 31st of May 2020. So this first flow chart, if you can see it, in the beginning, it shows the screening questions. So, and then it divides patients into three categories: the non-COVID, and then respiratory COVID, and the non-respiratory complaint, but in home quarantine. So the respiratory COVID are the patients that you might think of doing a chest X-ray for, and then proceeding from there. If the patient is not for admission, which means that the patient is stable, this patient will not be needing a nasopharyngeal swab. So you don't have to do a nasopharyngeal swab or a PCR test to diagnose all cases that you suspect need or have COVID-19. Only the patients that need admission in the orange box in the middle and the pink box that are unstable, you have to do the nasopharyngeal swab. Of course, donning your proper PPE for aerosolization procedure. Okay, so going to the next algorithm. This algorithm basically, or the flow chart, shows that the patients who are having non-respiratory symptoms. So these patients are in home quarantine, but they have symptoms like GI symptoms, for example, skin rash, or any other symptoms. So these patients will be provided with a nasopharyngeal swab only, again, if they need admission to the ward, or they need, for example, critical care like in the PICU. Otherwise, if this patient is stable enough to be sent home, you don't need to do a nasopharyngeal swab. And if the patient, for example, admitted to the ward, from there, the patient might be shifted will be shifted to the COVID area if he's positive. I'm going to discuss two cases. Case number 1, which is a 2-month-old boy presented with fever for 1 day. There was no cough, no vomiting, or diarrhea or rash. There was no decreased activity or feeding. The patient was clinically well. There was a history of contact with a COVID-19 case, which are both parents were positive. And on examination, the patient was afebrile at the time of presentation. His heart rate was 160. His saturation was 100% in room air, and there was no respiratory distress signs. He was conscious, alert, well-looking, well-hydrated, and feeding well. Systematic examination was within normal range. So this patient was admitted to the ward, to the COVID ward, and a full septic workup was done. and nasopharyngeal swab was taken in the ER and was awaiting result. The CBC showed a neutropenia. Other than that, all his labs were normal, including the lumbar puncture results. So this patient gives you an indication of how simple and straightforward cases can be with COVID-19, even though the patient presenting with only fever. Going to the next case, case 2. This is a 10-year-old boy, came with history of fever for 6 days, repeated vomiting and cough. He had skin rash and contact with a positive case of COVID-19 1 month back. Okay? On examination, the mother was positive actually. On examination, there was generalized macular rash. There were conjunctivitis on both eyes, non-purulent. Saturation was 97% in room air. His temperature was 38 degrees Celsius, and blood pressure was 70/40. The patient was conscious, alert, and responsive. Systemic examination showed tachycardia and bounding pulses, mild abdominal tenderness, and patient was diagnosed to have hypotensive shock. So, of course, the patient was already in the resus room. Fluid boluses were started and were given, and IV antibiotics were given in the first hour. Labs were collected, and the patient was kept on monitoring until the PICU team was contacted. I will show you a few of this patient's labs and the timeline. So this patient, for our luck to have the results, came to the ER 2 days back with a complaint of fever and vomiting, and he was treated accordingly with antiemetics and given IV fluids, and labs were done for him, and because all the labs were within normal range, almost, he was discharged home. So on day 1, you can see WBCs were 5.2, his hemoglobin was 11.5, and his platelets was 146. He had lymphocytes which were mildly low, 0.2, and then his PT, APTT, and INR were within normal range, on the higher range, but they were normal. D-dimer was not done initially, of course, in the first presentation. On the second presentation, you can see the WBCs rose up to 13.6, and the hemoglobin was 10.4. His platelets were slightly coming down, 122. And on this day, you can see that the lymphocytes were 1.1 absolute count, and the percentage was 8.3. And on that day, initially was not done, and the investigations were repeated on the same day, the third column. So you can see the PT 14.8, the APTT was 35.8, which was within normal, and the INR also was normal. The D-dimer was done at this time, and it was 1087. Continuing with the investigations, on the first presentation, as I mentioned earlier, you can see in the first column, all his investigations were within normal. So the BUN was 5.1 and the creatinine was 48. On the other hand, the second presentation, which is the admission presentation, or let's say the PICU presentation, the patient had a BUN of 12.4 and the creatinine was 220. His sodium was lowish, 129, was low actually, 129, and his potassium was within normal range. This patient, at this time, if you can see the difference between the CRP on the first presentation, which was 168, which was the only high parameter on the first presentation, and on the second presentation, which was our case, 378. PCT was done on the second presentation, which was 59. Troponin I was done later, 0.537, and the ferritin was 819. The urine routine was done for this patient, and the presentation it was negative, and blood culture and urine cultures were pending at the time. The nasopharyngeal swab was taken for this patient for COVID-19. Of course, the patient was admitted to PICU, and there the PCR testing came later on negative, but the rapid antigen detection test was done and came positive for IgG, which indicates that this patient was at that time, when he was in contact with his mom, he was positive, but later on, this is a sequelae of the disease, which is thought worldwide. So I've finished my talk, and just as a take-home message, I would say we are, and in the pediatric emergency room, we are the first line of defense for these patients, and we should have the high index of suspicion for the severe cases before the mild cases. So common is common. When you see a sick patient, this patient needs more attention, and always depend on the vital signs and your clinical sense. Thank you very much for your attention, and I will give the talk back to Dr. Fatoma.
Thank you so much, Dr. Leila, for this thorough presentation for suspected COVID slash confirmed COVID patients in pediatrics, and how do they present to the pediatric emergency department. That's very nice of you. And now we gonna move to Dr. Munira El Yassin, and she's gonna give us a talk about the management of the hospitalized patients of suspected slash confirmed COVID patients to the pediatric floor. And she's gonna talk about the prevention as well of the COVID-19 in pediatric population. Please, Dr. Munira.
Thank you, Dr. Fatoma and Dr. Leila, for the amazing presentations. Today, I'll be explaining about how to manage COVID-19 pediatric patients or suspected patients in the ward. So as Dr. Leila said, after it has been seen in the ER, the patient will be admitted in the COVID-19 suspected ward. So a quote that I like to start with is that to treat a disease, you win or you will lose. To treat a person, you guarantee you will win no matter what is the outcome. So what is important is the patient himself. So my outline is, first I'll start introduction, then I'll go with the cases, then I'll go with the red flags to monitor if we patient discharged to home quarantine and send home messages. So introduction. Who are the pediatric patients? They are pediatrics who are less than 12 years old, who are at higher risk for admission, usually who are less than 1 year, who has chronic diseases like diabetes, blood disorders, metabolic disorder, cerebral palsy, or a patient that has chronic liver disease or chronic kidney disease. Also, the immunosuppressed patient who are on chemotherapy, mostly the leukemia patient, or the patient on steroid, for example, nephrotic patient, or the patient who is post-organ transplant. Also, chronic pulmonary disease like moderate or severe asthma or primary ciliary dyskinesia, or patient with cystic fibrosis. Also, cardiovascular disease, for example, a patient has cardiomyopathy, or he was diagnosed with cyanotic congenital heart disease and he was not operated, or on anti-failure medication. So, who are the patients that are admitted to the COVID-19 ward? They are the patient who has persistent high-grade fever, who has persistent cough, the chest X-ray showed pneumonia or respiratory distress, or are not tolerating orally, or less than 1 year. Usually, these are the you have more suspicion toward them to be admitted. Also, if the patient has vomiting and diarrhea for more than 7 times and not tolerating orally and dehydrated clinically, then the patient needs to be admitted. Also, if a patient has fever and then develops seizures, also if a patient has has disturbed level of consciousness or has lost the level of consciousness, apnea or rash and prolonged fever, or if the patient looks ill or dehydrated. So to make it easier, we'll start case by case, and each case how we will manage the patient in the ward. So just a rule of thumb, pediatric patient, they are pediatric patient no matter what. However, they are in the corona era. So what's important is to stabilize the patient, airway, breathing, circulation, even if the patient is admitted to the ward. Then see the patient, judge him clinically, and then write your plan, and don't hesitate to ask for help. And the most important is the patient. If the patient is sick, try to stabilize and shift the patient to ICU. So the first case, this was run also by Dr. Leila, is that the patient is 28 days old, but he's the age is less, and with fever and runny nose, with decreased feeding and activity. So on examination, he was febrile, tachycardic, lethargic, but the motor reflex was weak, and other systemic examination unremarkable. The labs were normal. However, he had lymphocytes that are on the lower side, and the CRP are slightly high, which is 28. So what is important is to stabilize the patient. So to give him IV hydration and to monitor his vitals and to give him antibiotics. Then, as any rule of thumb, for any pediatric less than 60 days, we do full septic if the patient is with fever. So everything will be done, which is CBC, RFT, LFT, CRP, lumbar puncture for CSF, culture biochemistry and cell count, blood culture, urine culture, chest X-ray, and because of we are suspecting COVID-19, we'll add LDH, G6PD, and coagulation and D-dimer, and of course, swab PCR COVID-19 will be taken. So the treatment will be IV fluid, antibiotic that will cover the most common organisms in neonates, IV ampicillin and IV clavuron, an antimeningitic dose, antibiotic, and to monitor the vitals 4 hourly, and to monitor the activity and the feeding. Case 2, the patient was admitted with vomiting and diarrhea for 4 days. The vomiting 4 times, large amount, mostly food in content, then yellow color, and the diarrhea is about 7 times with large amount, non-bloody, and the fever for 2 days, and the patient is not tolerating orally. So the patient on examination, he looks ill, dehydrated, lethargic, but conscious. Capillary fill time was 3 seconds. Other system examination was unremarkable, except generalized tenderness of the abdomen. So the WBCs was 5, neutrophil was 0.5, lymphocytes were 4.5, CRP was 100, and he had AKI of creatinine 90 and BUN 7. So this is a simple gastroenteritis. However, because he was dehydrated and the creatinine is high, so he was admitted in the ward. So what is important is antibiotic and to give bolus, to repeat the bolus if the ER was taking bolus and you saw the patient and still the need of IV bolus to be repeated, you can give him repeated bolus and to give him 1.5 maintenance of IV fluid, and the investigation will be the same. However, instead there will be no CSF for that patient. The treatment is IV fluid, IV fluid, IV fluid, and antibiotic only if needed. The 3rd generation of cephalosporin, antibiotic, and to monitor, the most important is the blood pressure, to monitor it even with the vitals 4 hourly, and to reassess the patient activity and hydration. So another patient is 2 years old with known case of bronchial asthma on pulmicort, presented with fever for 4 days and cough for 1 week with mild chest pain for 1 day duration. On examination, febrile, tachycardic, tachypneic, subcostal retraction. Chest examination, there was decreased air entry on the right side with bilateral expiratory wheeze. Other system examination was unremarkable. So the WBCs was 10, lymphocyte was 0.5. Other than that, only capillary fill time, the CRP was 50. So the patient is admitted as a case of as a pneumonia, bronchial asthma exacerbated with pneumonia. So the chest X-ray showed pulmonary opacity on the right mid-lung. Because of the privacy of the patient, this picture was taken just from the internet. So the most important is to stabilize the patient, antibiotic, IV fluid, and the most important that if need nebulization, don't give the nebulization with nebulizer. No, we should, because because of the particles, we should not give it by the nebulization. It should be given by metered dose inhaler, the aero chamber, and should be given by Ventolin puffs. And the examination will be the same. Just remember, if there is a pneumonia, you have to do the chest X-ray, the LDH, the CK, the ferritinine, G6PD, coagulation D-dimer, troponin, and MRSA screen is important. MRSA screen is important because if there is MRSA, antibiotic for MRSA pneumonia has to be added. Also, an ECG should be done because of the management, you have to think about the hydroxychloroquine if it is needed, and the ECG has to be there as a baseline. And of course, the swab for PCR. So IV fluid, antibiotic, ceftriaxone, and if severe, you have to add hydroxychloroquine, azithromycin, and include MRSA antibiotic coverage. Just remember, ticoplanin is preferred than vancomycin. Antibiotic and Ventolin and Flexitide should be given through aero chamber. And most important is to monitor the activity and to reassess the patient hydration and chest using the accessory muscles. And note, if there is desaturation, if the patient is not co-oping with 5 liters or 10 liters of non-rebreather mask, you have to contact the PICU. So just a review, sorry, I don't know where it went. Yeah, just a summary about the treatment for the patient of the pneumonia is that there is mild pneumonia, there is severe pneumonia. Generally, the mild pneumonia, you have to require only supportive therapy. However, there has to be careful monitoring of the disease and to monitor if there is any progression. Start hydroxychloroquine for the patients who are at high risk for severe diseases. For example, a patient known case of asthma, a patient is known case of cystic fibrosis, or they are more suspicious. And if not tolerating orally, place an NGT. And if antibiotic is started, review the culture and review the PCR COVID-19 and evaluate after 48 to 72 hours. Severe pneumonia, consult infectious disease service for patients with severe or critical pneumonia. Empiric antibiotic therapy is not warranted unless a bacterial infection is suspected. Consider starting antibiotic if septic shock with piperacillin tazobactam. Start hydroxychloroquine for all patients with severe pneumonia. And the routine use of lopinavir and ritonavir is not recommended. However, it may be considered on case by case if the patient has severe or critical COVID. And if not tolerating orally, you have to place NGT. So note on some of the medication, the hydroxychloroquine, as I said, ECG has to be monitored for the QT interval. Just a review, for the infant less than 6 months, the normal is less than 0.49 seconds. For older than 6 months, less than 0.44 seconds. And G6PD level has to be monitored because with the hydroxychloroquine, it could cause acute hemolytic anemia. And patients with hydroxychloroquine and azithromycin, both of them may affect the electrolyte. Also, the patient with pre-existing asthma, use the bronchodilators only in cases of bronchoconstriction, because the bronchodilator, they will cause tachycardia, which will cause VQ mismatch. So we need to administer bronchodilator only with MDI spacer. If nebulization is used, airborne precautions should be implemented because it may cause worse in the transmission. Reserve the use of steroid in asthmatic patients to those with moderate to severe exacerbation. Just a review, Ventolin inhaler should be used by valve age-appropriate spacer, and for infants to 6 years old children, 2 to 6 puffs, usually 4 puffs every 20 minutes in the first hour, followed by the same 4 puffs every 1 to 4 hours as needed. And for the age from 6 to 12 years, usually we use 8 puffs every 20 minutes for the first hour if it is needed, and then followed every 2 hourly or 3 hourly or 4 hourly. And Flexitide should not be exceeded more than 500 microgram PD. So the fourth case, the patient admitted with history of 4 days fever and rash all over the body with decreased feeding and bony ache and vomiting before 2 days. On examination, he was febrile, tachycardic, dehydrated, blood pressure 80/40, ill-looking, maculopapular rash, and bilateral conjunctivitis. It's just a review of what Dr. Leila have been seen in the ER. So the patient, the same investigations, he was admitted to the ward. So what do we do in the ward? The same thing. Stabilize the patient, ABC, antibiotics, IV hydration, and balls could be given, but not to exceed more than 3 times. The investigations will be the same, blood virology, ECG, and swab. The treatment, IV fluid, antibiotic, if the patient is going into septic shock, include MRSA coverage if it is thought that there is MRSA in combination, but you have to adjust it for the creatinine. Antibiotic, and you have to monitor the blood pressure. And if the blood pressure is still low and the patient still look ill, the patient has to be shifted to PICU. But until the patient is shifted to PICU, we have to stabilize the patient in the ward until the shifting has to occur. And if the patient needs inotrope, the dopamine could be started in the ward and while contacting the PICU to monitor the activity and reassess the hydration. And to contact rheumatology as the patient, as we heard before, that the patient may have pediatric inflammatory multisystem syndrome. So just a quick review of what pediatric inflammatory multisystem syndrome is. Children and adolescents of 0 to 19 years old with fever more than 3 days and 2 of the following, either rash, bilateral conjunctivitis, or mucocutaneous inflammatory signs, second, hypotension or shock, third, features of myocardial dysfunction, pericarditis, valvulitis, or coronary abnormalities. Fourth, evidence of coagulopathy, and the patient may admit with acute gastroenteritis problem, diarrhea, vomiting, and abdominal pain, with elevated markers of ESR, CRP, PCT, and no other previous infection like bacterial infection, and evidence of COVID-19, either PCR, antigen, or serology positive. And they are most likely, they are contact with a patient that with COVID-19, and usually they are late presentation. So just remember, this is very important when we discharge a patient at home. For example, a patient is admitted as simple GE, and he tolerated and he became well, and we discharged him home. Or the patient is admitted as pneumonia and mild pneumonia and improved and discharged home. We have to tell the mother or the father that the mother has to monitor at least once the fever. We have to tell her if the fever came back more than 3 to 5 days and persisting for 38.5, has to come to the ER. Difficulty breathing, blue lips or face, persisting pain or pressure in the chest, worsening cough, no improvement of the symptoms, worsening food or activity, vomiting, diarrhea, skin rash or change in color, loss of consciousness, disturbed of consciousness, lethargy, coma, convulsion, dehydrated, or not very wet, and nabbies and sunken eyes, they have to come and to be seen in the ER again. So sent home message. Patients are treated as normal pediatric patients, but with more precautions and more investigations to be done. Treat the acute problem and don't forget the chronic disease to be monitored. For example, if the patient is known case of myoclonic seizures or a type of a seizure presented with static epileptics, stabilize the patient as seizures and then the neurologist to adjust the medication. For example, a patient is known cause of metabolic disorder, and he came with compensating or pneumonia, you have to treat him acutely and then contact them as subspecialty. And avoid nebulization and use MDI. Consult the subspecialty when needed. And just remember, you don't hesitate to ask for help. And for unstable patient, contact the PICU and try to stabilize the patient before shifting. So at the end, trust yourself. You know more than you think you do. And thank you so much.
Thank you very much, Dr. Munira, for this thorough and amazing, excellent presentation. And thank you very much. And we end our webinar, and hope you had an overview of pediatrics and how to manage, whether in the resuscitation, in the ER, or in the ward. Thank you. Bye-bye.